Good afternoon and welcome to the Center for Vaccine Preventable Diseases seminar series. My name is Sheza Fadl and I'm an assistant professor in the Clinical Public Health Division at the Dalla Lana School of Public Health and work for the Center for Vaccine Preventable Diseases. Throughout this year's series, we will feature researchers whose works align with the CVPD's themes. Those are vaccine hesitancy, value and impact of vaccines, immunization ethics and governance, as well as immunity and community protection. During today's session, Dr. Maya Goldenberg will be presenting on understanding and addressing vaccine hesitancy. After Dr. Goldenberg's presentation, we will have a moderated Q&A session led by Dr. Melody Song, our discussant for this afternoon. But before we start, I would like to acknowledge the traditional territories of the Mississauga of the New Credit First Nation, Anishinaabe, Wendat, Huron, and Haudenosaunee, indigenous peoples on which the Dalla Lana School of Public Health now stands. The territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and Confederacy of the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. We would also like to pay our respects to all our ancestors and to our present elders. Some housekeeping notes. Dr. Goldenberg's presentation will be followed by Q&A. And so please directly, it would be helpful for us because we have many people in this seminar today and we're very happy with the response and attendance. It would help us if you direct any questions that you'd like to be answered by Dr. Goldenberg in the chat box. And if you would like to read your question aloud, indicate so as well. But right now, if you would just put the chat in and we can do the best as we can. And we'll also put in an email address for some other questions where you can also submit questions to. So our speaker today, Dr. Maya Goldenberg, is an associate professor of philosophy at the University of Guelph. Her research is in philosophy of medicine and healthcare ethics, and is the author of Vaccine Hesitancy, Public Trust, Expertise, and the War on Science. And I will let Dr. Goldenberg first, and I'll introduce this discussant when it's time.
Okay, thank you. Thanks everyone for being here. Thank you, Shaza, for this really kind invitation. I'm very pleased to share my research with the public health community, and of course, eager to hear your questions and comments. Okay, so understanding and addressing vaccine hesitancy. Look, for any public health outreach effort or policy, anything regarding vaccination, to be, we want it to be well-grounded and of course, properly responsive. And to do that, we need to make sure that we're working with a good understanding of vaccine hesitancy, specifically the drivers of vaccine hesitancy. And that's my area of study. I'm a philosopher of science and medicine, and I spent the last 5 years researching and writing a book on vaccine hesitancy among parents in industrialized nations. So this cohort, parents in industrialized nations who hesitate about vaccines, has received a lot of attention by social scientists, by the news media, by very angry science bloggers, because they seem so odd. In industrialized nations, countries like Canada, pediatric vaccines are, for the most part, easy to access. Health systems are relatively stable, and there is so much vaccine information and communications about the strong scientific consensus on vaccines directed at the public. So what's going on here? When I started this research, this was around 2015, I had already unwittingly accepted the supposed truths about vaccine hesitators. First, that vaccine hesitators were missing some kind of key information or missing general understanding of science. In other words, science illiteracy caused vaccine hesitancy. The second one is that vaccine, and the second one is that vaccine hesitancy, vaccine hesitancy is a problem of privilege. The profile of vaccine hesitators in industrialized nations are seen as white and affluent people, usually mothers. So these ideas were very widely circulated. I'd already sort of accepted them before I even started the research. Eventually, I came to reject them both, but I didn't set out to deny those claims. I assumed they were true, and they shaped my initial thinking and my approach to the project. I'd started the project wondering what evidence was going to convince these people. What evidence was going to convince these people? That was my research question. And that's how most people seem to approach the problem of vaccine hesitancy. As an epistemologist focused on healthcare, I thought I was in a good position to find out. At the time, there wasn't any philosophical writing available to get me started, but I looked into science communications literature and I read vaccine hesitant patients' narratives, both personal accounts and qualitative research on vaccine hesitant parents. And it made me realize that I was asking the wrong question. The question isn't what evidence is going to convince them. The missing piece wasn't scientific evidence. It wasn't scientific misunderstanding and misinformation that was driving vaccine hesitancy, and even active disinformation, that's the making of intentional false claims, isn't the root cause. Instead, vaccine hesitancy signals a crisis of trust between the publics and the institutions that structure civic life. Public resistance to vaccines is a demand for institutional structures that are responsive to issues of justice and equity. That's what I argue in the book. Also, I say that all action should be tied to this understanding of vaccine hesitancy. So now, how did I come to see vaccine hesitancy this way, as a crisis of trust rather than a problem of scientific misunderstanding? Well, to start, vaccine hesitancy measures do not map onto levels of education. Highly educated people display the most polarized views on vaccines. They are among the strongest vaccine proponents, as well as the most hardened vaccine skeptics. So education and information does not, it seems, push everyone in favor of vaccination. By my reading of the many social science studies interviewing and surveying vaccine hesitant parents, parents understand the consensus on vaccines perfectly, but they question the integrity of those consensus claims. They just don't trust the source. So parents say this repeatedly and very clearly, that they are not comfortable with industry-funded biomedical research. The regulatory checks are seen as too weak, and so some vaccines may not be entirely safe. And even if most vaccines are safe, as some parents will allow, their kid might be the rare victim of a serious adverse event. So where is the scientific misunderstanding there? I don't see it. Yet the charge of scientific illiteracy still persists and dominates discussions about vaccine hesitancy. I find it to be a remarkably resilient explanation. In the face of a lot of counter evidence, it still prevails. Here is Neil deGrasse Tyson, probably the most famous science communicator in English language media, saying scientific illiteracy is a tragedy of our times, and he speaks of anti-vaccine views as illustrative of this. Science communications on vaccines as a result of this view tend to focus on knowledge transmission, especially debunking myths. If scientific illiteracy is the problem, then we need to fill that scientific gap, that knowledge deficit. Here are just a few examples on this slide of the kind of communications that you will see. Most of them look like this: just the facts, myth busting, lots of myth busting, that's for sure. So I'm trying to say that vaccine hesitancy represents so much more than scientific deficit, or whatever is being said here about knowledge deficit. It's for that reason I challenge the priority that's been placed on fact-checking and myth-busting as a mode of communication. It has some use for sure. I see no reason to stop it, but the attention and resources put into these efforts are not to scale with the diverse attentions and interventions needed for health outreach and communications. I'll speak to some of those near the end of this talk. Now, I'm ready to admit that the public debate over vaccines often look like a problem of scientific misunderstanding. That might partly explain why this explanation seems to endure, because we see examples of vaccine hesitators and refusers challenging scientific claims with very little ground for doing that. They make inaccurate statements like vaccines are not safe, vaccines are not effective, vaccines are not necessary. And this, of course, goes against the scientific consensus. So science illiteracy thesis might seem to fit here. But there is evidence coming from science communications research, science communications research into various forms of public resistance to scientific claims. And this research shows that public discourse on the status of science is often a very surface level debate, with science serving as a placeholder for the underlying values that are under threat. So people will argue about scientific facts and scientific points, but it's usually just representative of something deeper beneath, some kind of value conflict that doesn't get proper airing. And this might explain why it is that hot button scientific issues like climate change and GMOs, and of course vaccines, they divide along political partisan lines and not according to levels of education. Now, it is wrong to think that parents' vaccine confidence or hesitancy are purely cognitive or intellectual decisions. You read the science, you draw the conclusion. Instead, much more than scientific information goes into healthcare decisions. There are affective commitments as well as social connections to other people and to groups that shape our sense of identity and our understanding of things. So vaccine acceptance, vaccine hesitancy, also refusal, are shaped by the people you trust for vaccine advice. Even those of us who research and read the scientific literature rely on heuristics and cues from people who we trust for information. We do it all. We all do it, whether we're MDs, have a master's or a PhD. We do this to make sense of information, to get a sense of how much priority to assign to it, or whether we should ignore it. We do it to integrate the information, this new information, with other things we know and believe. So that trusted expert source on vaccines might be your physician or a public health officer, but circumstances and lived experiences lead some people to trust friends or internet chat groups or celebrity misinformants more than the conventional experts. Now, this phenomena is well known, and this has led some people to lament that expertise is dead. I don't think expertise is dead. Instead, expert authority needs more justification than the letters next to your name. The expert needs to be seen as trustworthy. Now, for that second supposed truth about vaccine hesitancy, the understanding that vaccine hesitancy is a problem of affluence. This idea stems from a flaw in the empirical research that does show higher household income to correlate with higher levels of vaccine hesitancy. So as I was working up, I'll explain, as I was working up my thesis that mistrust is the problem and not misunderstanding of science, this fact, this empirically verified fact, struck me as very unusual. It was the opposite of what you might expect, given the large body of research into trust in healthcare. In that body of work, racialized, disenfranchised, and otherwise marginalized people and groups tend to be the most reluctant to participate in healthcare. And these attitudes are grounded in historic and contemporary abuses and injustices in health research and in healthcare. So this seemed a little strange to me. Once I looked into it, I found what can go wrong when you approach empirical research without a good theoretical grounding. The studies measuring vaccine hesitancy, they employed sampling methods and measurement tools that biased the respondent pool. The researchers were not actively recruiting racialized people, and so the vaccine hesitancy research was reflecting the attitudes of the people most likely to fill out surveys and agree to interview requests. The little research that has been done shows far greater levels of vaccine hesitancy among racialized communities regarding pediatric vaccines. The characterization of vaccine hesitancy as a problem of affluence then does not seem to hold for pediatric vaccines, but still needs more research to justify that claim. Now, COVID vaccine hesitancy has been studied differently. Right from the beginning, there were surveys done using using better methods to get a more diverse respondent pool, and it showed from early on that racialized people expressed far less intention to vaccinate against COVID. This was in the New York Times some months ago, but it's not unique to the New York Times. The difference here is researchers bothered to ask and to investigate that question. Canadian media sources have also done a very commendable job highlighting the racialized dimension of vaccine hesitancy, and I really do appreciate that important attention. I'm just giving you a few examples here from CBC and Toronto Star. So what we find here is we have more hesitancy among people that face greater risk of morbidity and mortality from COVID. And its greater risk is due to socioeconomic circumstances like one's employment and living conditions. Now, these risks, of course, stem from structural discrimination, and vaccine hesitancy thereby, at least vaccine hesitancy about COVID vaccines, stem from a rational mistrust of the institutional apparatuses that put people at unequal risk of harm from the disease. I think this Toronto Star title says it all. My mom says she'll refuse the COVID vaccine. Why? She was once neglected by the health system when she almost lost her life. Why should you trust them now? Same goes for people living in COVID hotspots, these communities that were not kept safe because many of its members can't work from home and don't have paid sick leave. Why trust the system now? Surya Ibrahim is a community activist, co-founder of the Regent Park Mothers for Peace. She actually cast a wider net in characterizing the imbalance of priority placed on vaccinating at-risk communities. She was described in the Globe and Mail as incensed that gun violence and homelessness in her community have not been given the same sort of attention and resources that vaccines have. She's quoted saying, "We are not getting the basic stuff we need, so why are you just forcing a vaccine on them?" Now, I've already suggested that what you know and who you trust are closely allied. Knowledge is social that way. So we can attend to arguments and evidence, but we also rely on the expertise of others because we don't have the expertise to know for ourselves in some cases, or because we just don't have the time to study the issues comprehensively. There's just too much for us to know. Now, the term for this, what I'm describing here in the philosophy literature, is epistemic trust. The term I've noticed has migrated into the psychology literature too. So to invest epistemic trust, just to define it, to invest epistemic trust in someone is to trust them in their capacity as a provider of information. So when we trust a person, an organization, or an institution, it's dependable and worthy of our confidence, and we will be more likely to listen to what they have to say. Now, both areas of research, epistemology, that's the study of knowledge in philosophy, and in psychology, both those areas say that you won't get very far without some degree of epistemic trust. You won't know very much, says the epistemologists, and some psychologists tie the inability to confer epistemic trust to others as with psychopathology. But still, you need to hone those skills to trust the right informants. There's always risk involved. On the flip side, those who want to stand out as trusted informants, perhaps on matters of public health, need to earn and maintain the trust of those they want to inform, say members of the public. So vaccine hesitancy hinges on good trust relations. The trust of vaccine, the research on vaccine confidence and hesitancy bears this out. So I want to talk here, give you just a snapshot of some of the research. I like to think of vaccination as an act of civic engagement, and that civic participation is steered by confidence in scientific, political, and regulatory processes. So some evidence of this. There was research from both the US and France of H1N1 vaccine uptake during the 2009 pandemic. And it found that among members of the public, those who trusted the government's ability to deal with an epidemic were almost 3 times more likely to take the vaccine than those who did not. That was true in the US and in France in 2 separate studies. The same point about confidence in government was made by the US National Vaccine Advisory Committee on the state of vaccine confidence in the US in a 2015 report. They cited 3 levers of trust that influence vaccine confidence and hesitancy: the levels of trust parents have in government, the healthcare system, and their healthcare providers are often associated with their ultimate decision to either accept or refuse vaccinations for their children. Also, the research team led by Heidi Larson, the team responsible for the Global Vaccine Confidence Index, that's a repeated poll of tens of thousands of people in over 100 countries, similarly explain that confidence implies trust in the vaccine, that's the product, trust in the vaccinator or other health professionals, that's the provider, and trust in those making the decisions about vaccine provision, that's the policymaker. Another source, this is the 2018 Wellcome Global Monitor, gauging public attitudes towards science and health, a study of over 140,000 respondents in 140 countries, gives some indication that we might look beyond the healthcare system to the system more generally when thinking about vaccine confidence and hesitancy. Here's a quote from the report: "The level of confidence people have in their national institutions, their government, judicial system, and military was a good predictor of their level of trust in science. This suggests that we cannot ignore how people feel about their broader social context and their relationship with power and institutions, even though they ultimately tend to trust scientists more than government or military." Okay, so that's broadening the scope of the factors that loop into vaccine confidence and hesitancy. Finally, a global survey of COVID vaccine confidence done by that same global index group. This happened in June 2020, 13,426 people in 119 countries. They found 71.5% of participants reported that they would be very or somewhat likely to take a COVID vaccine. Of course, that varied quite a bit from country to country. And the researchers importantly found respondents who said that they trusted their government were more likely to accept a vaccine than those who said they did not. So what needs to be done to address vaccine hesitancy? The answer is you need to address the sources of mistrust. So I'm adding this on top of the sort of fact-based scientific information that we need out there. Need to address the sources of mistrust. Now, going back to my research on pediatric vaccines, I identified 2 key sources of vaccine hesitancy. I already hinted at them. One was financial conflicts of interest in health science, in health research and healthcare. Parents are very clear about that. And the underexplored impact of medical racism and health injustices, both past and present, on vaccine attitudes. Now, the new COVID vaccines appeared to struggle with the same 2 sources of mistrust, but then I want to add a bunch more just to make it more complicated. One is financial conflicts of interest. We are watching the unfolding of vaccine licensing agreements, the global distribution of vaccines, which are largely going to wealthy nations, the higher cost per dose that lower income countries are paying. These are highly inequitable and highly problematic. We need at this point grand efforts towards global solidarity to get a good vaccination program going, and they are being stymied by business interests. That is not public trust inducing, and of course they are not promoting public health either. The response to COVID vaccines by racialized members of communities has already been discussed. It is clearly the case around COVID vaccines. And of course, there's new dimensions of the COVID vaccines. As if the first 2 sources weren't demanding enough. The publics are trying to make sense of these new technologies using new platforms. I'm referring to mRNA vaccines. They were developed so quickly. There's the prospect of increased gatekeeping function for those vaccines. We are hearing already about vaccine passports that will legitimate restricted access to travel, to stadium events, even employment. Thinking about Ontario, school entry vaccine requirements for pediatric vaccines were not much of a lightning rod in Ontario. We're kind of used to them. Our exemption clauses seem to help mitigate the potential backlash, but these new proposals will surely activate and energize public resistance. And of course, this loops back to vaccine hesitancy and refusal. Now, if trust needs to be maintained in the product, the provider, and the policymaker, I'm just following that 3-part distinction that was made earlier, We need to address those areas where mistrust seeps into all three. So regarding the product, we need easily accessible and independently vetted information. When the COVID vaccines were first announced and quickly authorized for emergency use, this is just roughly January of this year, it was hard to figure out what information was coming from Pfizer and Moderna press releases and what had been independently confirmed. I'm a pretty good newsreader, and even I was struggling to see which was which. The sort of great day for science narrative that was played out in the media was inspiring, especially after so many months of bad news, but it made the information people needed to make informed decisions difficult to find. As for trust in the provider, we need the use of trusted local messengers. That is so important, knowing that there are communities who mistrust the healthcare system, whether due to historic or current experiences of racism. The use of local and trusted messengers is an essential way to get information across. These are typically community activists and healthcare workers and scientists from these communities that are struggling with vaccine information. Hearing from trusted sources are known to make a difference. So there is good grassroots community activism happening in Toronto right now. There's the good work of the South Asian COVID Task Force, that's Canada-wide. There's the Toronto Black COVID Task Force. These two groups, these task forces are two examples of excellent leadership and outreach. For example, the Toronto Black COVID Task Force hosted a webinar earlier this month. It was open for all. It was a chance to learn and ask questions about COVID vaccines. And the title of the seminar was The Historical and Contemporary Issues of Trustworthiness Vis-a-vis Vaccines and Medical Science That Give Black People Cause for Concern. The speakers did not shy away from this painful tension in their own and in their community's healthcare decision-making. So this kind of localized outreach offers culturally sensitive and trauma-informed COVID and COVID vaccine information. It's meant to reduce hesitancy around vaccines, stigma around testing, and to encourage safer practices in people's everyday lives. They are also attentive to the structural barriers that keep their communities from being safe, food insecurity, workplace concerns, financial and housing instability, and of course, a healthcare system that can provide suboptimal care. So healthcare providers, at least in the context of vaccine, around pediatric vaccines, they remain the most enlisted source for vaccine-related information. That might be lesser so during COVID because we don't have the same kind of access to physicians. But their credibility, the credibility of healthcare providers pushes against general mistrust of the health systems that they work within. So the healthcare system itself needs some scrutiny and some change. Even the perception of poorly managed financial conflicts of interest is damaging to patient care and to public health. If ever there was a time to create more safeguards and more distance between industry influence and health research and practice, this is it. I know this is a heavy demand. Those with the power to enact such change benefit greatly from these close relationships. They're quite lucrative between industry, health research, healthcare, and government. But the looming obstacle that poor public trust presents to public health ought to give everyone serious pause about whether this common practice really needs or should continue. All the while, not all health practitioners are equally trusted by all patients. There is a constant need for training in anti-oppressive practice. This is to counter racism and other biases that impact the relationships of health providers and systems to their public stakeholders. We want to avoid the pitfalls of racist thinking and speech. They harm patients. We want to avoid epistemic injustices. That is, this term means excluding or silencing people's knowledge claims. It means doctors need to take their patients' complaints and questions seriously. Don't assume that patients are exaggerating about their symptoms, especially pain, due to racial or gender biased thinking. It means doctors should not be dismissing or shutting down mothers who have questions about their children's vaccines. I'm saying this because that happens a lot. It is recorded in the narratives and research on vaccine hesitant mothers. Their stories often begin with a mother having a bad visit at her pediatrician's office. Then she goes online and finds the community and the support that she needs. We certainly need to be attentive to the concerns of patients about COVID vaccines. It is not an obvious risk-benefit choice in favor of vaccines among many members of the public, even those who are most at risk of COVID complications and death, sometimes especially those who lack the social supports, whose lack of social support have put them in this vulnerable position. So all conversations should begin with, you are right to ask questions and you should ask questions. Tell us what you need to know. And lastly, of course, representation matters. Active recruitment and retention in every healthcare and public health training program, in faculty hiring, and in all levels of staffing. That increases public trust. Finally, to the policymakers, the government, the advice here is listen to the voices of the most vaccine hesitant. They are calling for justice and equity. Some are living in neighborhoods that need much more than vaccines to bolster public health. There is a strong case for social determinants of health to curb vaccine hesitancy and also to reap the many other benefits in terms of health outcomes. And that are my suggestions for how to address the sources of mistrust. I think I will stop there. That's pretty much what I wanted to say. Thank you for listening. Email me here.
Thank you so much, Dr. Goldenberg, for this excellent talk. And I would like to next introduce our discussant. Dr. Melody Song is a Canadian Institute of Health Research Health System Impact Fellow at Public Health Ontario. At PHO, she is exploring stakeholder perspectives on artificial intelligence for equitable immunization delivery. She's also a research collaborator at the Ted Rogers School of Management Social Media Lab at Ryerson University, specializing in social media network analysis on vaccine misinformation. So, Dr. Song, go ahead for your discussion.
Thank you, Shaza, for the introduction, and thank you, that was a fantastic presentation. I really enjoyed every minute of it. I'm sure all the participants are, and selfishly, because my interest, part of it has also been in vaccine hesitancy. And so I'm gonna start asking some of the questions that hopefully can spark some thought on how we proceed in gaining public trust in these sectors in practice and policy making and for all purposes. When I look at your presentation, what really sparked my interest was that the idea of crisis of trust in the context of a public health practice, when people in these professions have limited time and or no mandate to serve these to establish trust. At least it's not directly said, because trust is so hard to measure. The first question is how do we go about this in a more applied way? And I'm opening this discussion to people who are participants in this presentation as well. But also the second question is, I also feel like these problems that you presented are a contention between freedom of asking questions and neoliberalism concerning, control and big pharma with, traditional ways of relating to one another. And so these are two questions that I immediately have. And Maya, please let me know if you have some thoughts on these two. Thank you.
Thank you. Now there are methods for increasing trust and engaging them. So and they're going to be very localized. So all I can give are sort of general principles. Building trust takes time, and that's always a difficulty, especially for healthcare providers are known, especially physicians are known to be the primary source where people get their vaccine information. And of course, they struggle with time because it might, to really do it well, you might need to build up a relationship, have many repeated conversations, maybe even have a patient come back a few times with their baby before they feel comfortable to do it. And that, of course, is the most difficult thing for a family provider. So, I would first say we need the structural support, the kind of billing that physicians do around vaccinating children. It was set in Ontario. It was probably set at a time when it was a quick conversation and a quick, here you go, here's the jab. It's not like that anymore. So people deserve the time to do that because it might be more than a 5-minute conversation. Further, it requires a consistency in the practice that people are seeing the same physician more than once. And if not a physician, then a nurse practitioner is also very good to provide. It's been noticed that that is a very inefficient way of doing things where you're having these one-on-one conversations. And the worry had been until COVID that maybe that was just something we had to accept. But in our COVID times, we've made incredible use of internet technology, these kind of town hall meetings on Zoom, like the COVID task force meeting that I just mentioned, are apparently doing a lot of what we didn't think they could do before. And that just might be our changed circumstances, that perhaps these community meetings can be effective, maybe not in a doctor's office, which was how they had been envisioned and were seen as impersonal, but sitting in your living room in what feels like a safer and more comfortable space, that might be the way to do it. But it is time consuming all the way. So it's a question about what kind of priority and resources we want to put into it. I'm not willing to just say, that's too expensive, that's too time consuming. Let's make a better pamphlet, because I don't think the pamphlets are doing very much.
I love that you said the pamphlets. I really get really tired of looking at the similar pamphlets that says vaccines are safe. And there are some questions in the audience, from the audience, that are very interesting. Maria Sundaram has asked, be curious to hear your thoughts on provider-based presumptive communication about vaccines, as opposed to more participatory approaches such as motivational interviewing.
Right. So I've heard good things about both, at least for pediatric vaccines, the presumptive language, like pretty much the doctor saying, okay, we're getting our vaccines today to the mother, as opposed to, can we talk about vaccines today, seems to make parents more likely to vaccinate their kids. It is unclear that will translate towards COVID vaccination, just because the communications landscape and the context are so different. Motivational interviewing is a funny thing. There have been huge successes with motivational interviewing, but it seems to be that it's so specific to the context and the interviewer that it's hard for behavioral scientists to point to it and say, here's a statistically significant finding around it. Yet the anecdote, maybe deserves more than anecdote. Let's just say the small scale findings seem very compelling, and they seem very trust enabling, at least based on the sort of psychology and philosophical and social science work on trust building measures. Is you treat people with respect and you ask them what they think instead of telling them what they think. You're probably going to break down some of the defenses than if you say to someone, what kind of selfish mother wouldn't vaccinate their child? What's wrong with you, right? So motivational interviewing, I think, deserves more attention, but I understand that it has not been able to gather the kind of statistically significant research evidence that we need to really push it forward. I still think there's something there.
I definitely agree, and really good point about balancing the funding schemes that current healthcare systems have with a new way of thinking about how to engage community. And the other question from Bethany, we have another question from Bethany about community ambassadors. As a healthcare provider in New Orleans who provides medical care to our culture bearers and musicians, how important is it to engage those who receive the COVID vaccine in reaching out to others in their community to reduce hesitancy?
It's probably a very good idea to do that, because one thing that we do know that makes vaccines more acceptable is the normalizing of it. So it shouldn't have been too surprising that a lot of people heard about these COVID vaccines and said, I'm interested, I just don't want to be first. But as we see other people start doing it, and it becomes a normal thing to do, those initial fears, of course, can be managed. You get to hear what it's like, what people experienced. So the normalizing behavior of, let's say, we have this in Ontario of, let's say, vaccinating your kids before they go to daycare, is more likely to get other people to do it, because it's not that people aren't, independently concerned and have their specific concerns, but we look at what our peers and our friends are doing. And when we see other people that we trust vaccinating, then we are more likely to do it ourselves. If anything, we can ask the targeted questions to people we trust. I know you got vaccinated. Tell me what it was like. Tell me what your concerns were and why you still got vaccinated. That goes a long way. I think that's what people were trying to do in our admittedly slow rollout of vaccines in Ontario. The doctor is putting their selfies up on Twitter just to show, look, I'm doing it too. You can do it too. It's a way of normalizing the practice.
And going back to your question on arguments against vaccines, one of the things you said was uncertainty about limitations of science. And with a quick vaccine rollout, a lot of people are asking what is a long-term effect. And so Elise from the audience says, what is your perspective on vaccine hesitancy due to the realities of the limitations of science? For instance, not having long-term observation to understand these effects and efficacy. What's your point in communicating trust when it comes to limited evidence?
There is research evidence to show that the public can handle the truth. So you can admit to uncertainty, tell people what is known, what is not known, so that they can make informed choices. The worst thing that can be done, and this has been done historically around large public health campaigns, is overstate the case. Let's say, try to be so worried that the public is going to overreact to some kind of uncertainty or some kind of danger. And so you overstate it, you try to suppress the kind of information you don't want to share, and then the public ends up very mistrusting of the source. So the best thing you can do is admit, we don't have the long-term data, but here's what we do know. I've heard some nice versions of this around COVID. That's science communicators on social media and otherwise saying, look, we don't have long-term data because it is a new vaccine, but we know that most serious adverse events happen within, and some happen within the first 15 minutes, many more happen within the first, let's say, 2 months. We have the 2-month data, so we can say that at least many of the concerns that you might have already been investigated. Then the public knows that there's still long-term that we don't have, then they can make an informed choice about whether they think that is a risk worth taking. Some people may decide it isn't a risk worth taking, but at least everyone has the information to make an informed choice instead of letting sort of fears and misinformation spiral out of control. So admit what you know and admit what you don't know. That is always the best way.
We know in Canada, it's a very diverse population, and many newcomers are coming in, trying to establish new lives. And what is your recommendation, Yvonne asks, for building trust with newcomer populations? What resources and actions, if any, would you suggest healthcare providers consult and do?
I think getting in touch with the local, use the local messenger angle. There have been good success with, I'd mentioned these task forces, getting scientists and doctors from the communities that is, if it's new communities that speak the language of new Canadian communities, getting religious leaders, people that are trusted and influential for good reasons within new Canadian communities. These are the resources you want to bring in, not to get them to understand the importance of vaccines, to explain what we know about it, what we don't know about it, and they can deliver the message in a way that's going to be culturally sensitive and appropriate for their community.
And this is an interesting point, because in my research with social media platforms, different populations and age groups and gender use different types of resources. So it's hard to reach out to all these people. And one of the direct ways perhaps is to establish a good trusting employee-employee relationship where, you know, you have the direct approach of communicating health beliefs even in your vicinity. So what are your thoughts on incentivizing, this is a question from Segun, knowing that there are imbalanced power dynamics between employer and employee, what are your thoughts on incentivizing vaccine uptake to address vaccine hesitancy in this climate? Is it an approach that will give short-term gain, but not the long-term goal of trust?
Yeah, I would like more research into that because I could see it going very badly. Of course, people like incentives. People often respond well to things. Um, However, it needs to be done in the right way. An incentive can be a way to get people along to feel good about the decision. It can also be seen as sneaky. So I think the context really matters. I've been tracking some of those accounts. I was reading in the US about difficulty trying to get long-term care workers to get vaccinated, a problem in Canada too. And there are major employers that are giving free breakfasts and coupons and things like that, and apparently getting good uptake. And of course, that was framed as, see, there's a success story. But of course, I wasn't so sure. I said, is that a sign of good? Is that a sign of building confidence and building better relationships? Because down the road, if people say, I took the breakfast because, I don't know, because I'm hungry, that's not a good version of incentivizing. So any behavioral researchers will tell you incentives need to be done right. So the context will matter. I'm not against using it, but it's really can't be seen. Incentives need to be truly chosen. It can't be something that people are obviously going to pick because they have very few resources or very few choices.
And we still have a lot of questions coming in. I'll circle back to something that you mentioned about perhaps establishing social norms is more important than having incentives. Have you thought, this is for academics, have you thought about co-exploring these epistemologies, such as funding of racial equality work, funding work with BIPOC, with researchers from disciplines from psychology, especially those who are trained in public health and global health? It would be a great idea if we could do it together. And this is a question from Maria and Mahaswar.
Great question. And yes, I mean, these kinds of complex problems need interdisciplinary research. So yes, bringing in sort of how is it being utilized and studied in different disciplines would be very enriching and very informative.
And I think there are still some questions. Elise says, what about addressing some vaccine hesitant? Sorry, I don't get the question. Sorry, I don't, it's a very last question. It says, what about addressing what some vaccine hesitant do trust? Sometimes trusting in nature, the universe, God, and that vaccines are going against nature.
So these are sort of arguments about the naturalness of vaccines. It is a common concern that comes up. I will say sometimes it's religious, sometimes it's more of a secular worldview about the natural. I've heard this before. I don't find it to be very common. I still think the conflicts of interest and why should I trust the government comments are still more common. There isn't a one way to talk to anybody about these kinds of concerns. I mean, the kind of research that's actually been shown to may have any effect is doing things like, if you're having a conversation with a person, with a friend or a family member, is try to be non-judgmental, and sometimes it's hard to be. We're living in stressful times, so our instinct to yell at people that don't agree with us is strong, especially on social media. Try to avoid doing that. But things like try to understand where their concern is coming from. So they say it's not natural. You might ask, like, where does this idea of naturalness come from? It might be grounded in their religion. It might be elsewhere. Why is the idea of naturalness more important to them? What maybe that those kinds of conversations can sometimes open up new channels for what is the fear that is driving this kind of response, and then you can have a decent conversation. It should never be aimed at trying to convince someone. Especially the scientists in the room, resist the urge to ply people with facts. That gets people's backs up. Do a little more listening and a little less telling, and you might actually find it very, very instructive. I'd also suggest don't try to change their mind. Listen it out, because people do a lot of thinking and talking at the same time. So you might find that some of the resistance breaks down just by people articulating the fears that they have. I can't say for sure. This is just, good practice in terms of respectful conversation, but that really is all we know to be helpful for discussing vaccine hesitancy with someone who is otherwise unwilling to talk about it. The fact that you even are talking to them is something.
And thank you so much, Maya. On that note, I'm going to hand the presentation back to Shaza. Shaza, please.
All right, thank you so much, Dr. Goldenberg. That was an excellent talk, and thank you for everyone who participated and the questions that have come in, and thank you for taking time to answer so many questions that came in. So I'm really happy with the conversation. I hope everybody enjoyed it. And I do have to say, like somebody who's come from in my work on vaccines has been mostly focused on impact of vaccine population level, immunology, epidemiology, but with COVID, I've definitely been in front and face and having to deal in the community and working with a multi-ethnic group and religious religious scholars who've actually pushed many scientists of like, okay, help, like, people are coming to us, and just, and they were the champions pushing through. So it's been a really great and learning experience, and it's been great to see people from all over different disciplines coming up and stepping up to provide that type of conversation. So it's been if everybody can, there's a link in the chat for the evaluation of the program. It would be really like to have some of your feedback, and I think to continue the seminar series. We thank everybody. Thank you so much, Dr. Goldberg, for the excellent presentation. And any final thoughts that you'd like to share with us too before we head off?
No, I think I said everything I wanted to say. Thank you for coming, everyone. And this is a conversation and an area of study that is far from over. So we'll have more to talk about, I think.
Okay. All right. Thank you very much. And I'm giving everybody back a 5-minute day in their day. And thank you very much and have a good day.